Yeah, we are live now, sir.
यार
Good evening,
गाने
Manish sir.
गाने
Manish
किसके
sir,
चल
we
रहा
can
है?
start, sir.
Yeah. Good evening, everyone. And let me share my slide. I am Dr. Manish Dhawan. I am the moderator for this webinar. Let me share my slides. Is it visible?
Yeah, please put it on slide mode, sir.
Yeah,
go
one
ahead.
minute.
Go ahead, sir.
So, good evening, everyone. And this is the module 13 of IOA PG E-Platform. And today's topic is musculoskeletal oncology. And I'm Dr. Manish Dhawan. I am the webinar moderator. And I'm also president of Asami, and I work as a senior consultant and professor of orthopedics at Gangaram Institute of Postgraduate and Medical Science. So I'll just introduce you to the IOA team. And so the team IOA is our president RC Meena, Dr. B. Shiv Shankar, he is the president-elect, Dr. Ramesh Sin is the vice president, Dr. Atul Srivastava is the secretary of IOA, Dr. Sandeep Kumar is joint secretary, Sanjay Dhawan is the joint secretary, and we have a very renowned IOA PG teaching committee with a lot of renowned professors like Dr. Raj Gopalan, Dr. Harsha Shah, Dr. M. Roy, and Dr. Rajesh Goyal. Now, today's faculty is Dr. Professor N.K. Maggu and Dr. Deepak Maravi, Dr. P.K. Raju, Dr. N.K. Das, Dr. Brijesh Nandan, and our webinar co-coordinator is Dr. Ravi Chauhan. So let me give the scientific program now. And first short case will be given on osteosarcoma will be given by Professor Maggu. Then another discussion, we will have a kind of a X-ray presentation, and we can have a discuss. It might not be just a PPT, but we will have a discussion. Then a short case giant cell tumor by Dr. P.K. Raju, short case enchondroma by Dr. N.K. Das, and short case osteochondroma by Dr. Brijesh Nandan. Now, introducing Professor N.K. Maggu, he is senior consultant orthopedics at and hip and pelvic acetabular surgeon at Max Super Speciality Hospital, Saket. He also has interest in bone tumors. He is the past chairman, Ethical Committee, University of Health and Sciences, Rohtak, former senior professor and head of Department of Orthopedics at Rohtak, chaired numerous sessions at various national and international platforms, delivered numerous lectures at various state, national, and international platforms, contributed to numerous chapters in various reputed books such as Campbell Orthopedics. And Dr. Deepak Maravi, he's a professor, Department of Orthopedics at Gandhi Medical College, Bhopal. He is faculty for teaching various PG teaching courses since many years around the country. He has total teaching experience of more than 15 years. Dr. P.K. Raju is professor, Bangalore Medical College and Research Institute, Victoria Hospital, Bangalore. He's fellow in joint replacement surgery. He has AO trauma faculty. He's a AO trauma faculty for basic, advanced, and pelvic acetabular courses. He is a DNB faculty for PG courses. He has 24 international publications, member academic council and board of studies at RGUS. Dr. N.K. Das is professor and head of department of orthopedics at KPC Medical College, Jadavpur. He is external faculty for Master Biomedical Engineering, School of Biomedical Science, Jadavpur University, examiner and paper setter since 1994. He has active participation as a co-guide for preparation of dissertation and thesis for engineering students. 50 plus papers presented in different national and international conferences, delivered 4 CME lectures in IOCON 2004, 2005, 2007, and 2012. One CME lecture in Golden Jubilee Pedicon in 2013. He has, given a lot of guest lectures in different conferences and 10 papers published in different state, national and international journals, and he has also contributed to book chapters. Dr. Brijesh Nandan is a dynamic young ortho-oncology surgeon, and he is a musculoskeletal oncosurgeon. He is working at Sir Gangaram Hospital, New Delhi. He's trained in musculoskeletal oncology at Tata Memorial Hospital, delivered numerous lectures at various state and national platforms, has many publications in national and international journals, chaired many sessions in various prestigious platforms. So I welcome you all, and without wasting time, I request Professor Narendra Kumar Maggu to start his presentation. Dr. Maggu, please.
Yeah, please. How? Yeah. But I should share the screen again.
Yes, sir. Yes, sir.
Yes, and this is the one.
Yeah, sir, it's coming.
Yeah, sir. Please put it on the slide mode. Yeah, full screen slide mode.
Is it okay now?
No, sir. Come on the. Yes, now it is okay, sir. You can
Go ahead.
start now.
Okay.
Yeah, now it's all right.
Thank you, faculty and the esteemed members of IOA EC and participants. I talk to you on osteosarcoma. Once a case is seen in the ward, wherever examination is held, this case is always given to the candidates. Please be clear. All the candidates must be clear. A tumor case, if available in the ward, shall always be given to the examinees. I have taken help and some slides of Dr. Zile Singh Kundu, who is masterly doing this work on oncology. A lot of work is done in our Department of Orthopedics at PGE Rohtak. Everybody knows that. So osteosarcoma is defined as when the primitive mesenchymal tissue goes into osteoid formation directly. So that is the principal definition of osteosarcoma, that the principal or the primary mesenchymal cells, they lay down osteoid directly. More commonly seen in males, just introducing 3-4 slides, and then I'll come with the case presentation, the way we do in examination, and the candidate should be aware of that. Metaphyseal ends of the long bones, the common occurrence site, most commonly seen at the distal end of femur, 42%. Then proximal end of tibia, about 19%, and proximal humerus, that is third in order as far as this tumor is concerned. So histopathologically, demonstration of osteoid directly formed by the malignant cells is essential for the making of diagnosis of osteosarcoma. That is the most important as far as diagnosis is concerned. Demonstration of osteoid directly from the malignant cells. It can be primary, it can be secondary. Primary is again of two types. When it is intramedullary, most commonly seen in 80% of the patients, or it is surface. Surface means it is outside the cortex, maybe parosteal, maybe periosteal. And intramedullary, it is conventional intramedullary, the central high-grade type. It could be osteoblastic type in 50% of the patients. Again, histopathological, chondroblastic in 25%, and fibroblastic in 25% of the patients again. Now this is parosteal, periosteal, and high grade. Parosteal means just outside the cortex, outside the periosteum, and periosteal osteosarcoma means when it is growing from the germinal layer of the periosteum. So these are the varieties, the intramedullary and the surface osteosarcomas. Secondary osteosarcoma can be seen in Paget's disease, not very commonly seen in this country. It can be seen at the site of radiation exposure, like skin. In other tumors, like an osteoblastoma can transform into osteosarcoma. It could be a osteochondroma. Again, the cartilage part or the bony part can transform into osteosarcoma and fibrous dysplasia. Similarly, non-neoplastic conditions like osteomyelitis, chronic one for years and years, bone infarcts, and metal prosthesis implantation can also turn into secondary type of osteosarcoma. So osteosarcoma, when a short case is given to the candidate, it is more of a clinical examination than a history taking. Candidates must remember. You ask detailed history when it is a long case. Do detailed examination. I think 10 minutes or 12 minutes are given for a short case. So it is more of a clinical examination than history taking. At the most, you can ask 2 or 3 questions to the patient and draw your conclusion after doing thorough clinical examination. Examiner will ask the candidate the way they are shifted on the table of the candidate, or they call the patient where they are sitting as a group, that what is your diagnosis? That is the first question. What is the short case? And the candidate will reply, it's a malignant growth at the distal end of femur in a, say, 14 years male child or a 16-year male child or a female child. I have written male because mostly seen in males, probably osteogenic sarcoma. So he will say, sir, malignant tumor at the distal end of femur in a 14 years male child, probably it is osteogenic sarcoma. That's my diagnosis. And the examiner will say, why is it malignant swelling? The very first question say, why do you say it is a malignant swelling? That is the format I have prepared. That is how we take the examination. And that is how Professor Raj Gopalan and all my other colleagues, Professor Ray and other friends, they know how the case is given and how it is presented. So why is it a malignant swelling? The candidate should not get nervous. He should say, sir, rapidly, progressively growing swelling started as a peanut size, very small to begin with, like a chana, like a peanut, rapidly growing, attained huge size in just short duration of time, preceded by pain. Patient complained of pain, which you ask in history. Sir, he had pain initially for a few days or few weeks, a small swelling, and then a huge mass. And history of loss of weight and appetite, he will tell you, and you can say that the child is emaciated. You see this picture, he is emaciated. And this huge mass, which was in our world, and I made the picture that time and asked my colleagues like Dr. Batra, yeah, such those pictures because I have to talk to the candidates on osteosarcoma. Okay, then describe the swelling. When the examiner feels satisfied that he says it is rapidly, progressively growing swelling in a very short time, attained huge size. So he said, okay, describe the swelling then. It could be his next question. So you have to describe, keeping in mind inspection, palpation, all those things, not a way. That is an order, the way you should describe a swelling or a tumor or a case otherwise. And the first thing you will say, the site, size, shape. On inspection, you will say, but the site, size, and shape, it's a huge swelling of the size, you will say it is 12 inches into 14 inches, like that. You'll describe the swelling, it is a globular, or it is like a balloon, it is a bursting swelling. And then say at the distal end of femur or proximal end of tibia. So site, size, shape, location, the site of the tumor, the swelling, size, I have told you here, 14 into 10 inches, just arbitrarily, which I'm thinking on this patient. Globular in shape, like a balloon, and it is all round the bone, or anteriorly, posteriorly, medially, laterally. Ill-defined margins, that is very important. Margins are ill-defined. In a benign swelling, the margins are well-defined. In osteochondroma, the margins are well-defined, but in a malignant swelling, permeative, the margins are ill-defined. You see here, you have to tell on inspection. Overlying skin is shiny and there are veins, a lot of veins. There could be lobular. You see here, one lobule is this, other is this main. So overlying skin is shiny with veins prominently seen, you would say. And gauge veins, I'm telling here, single with pigments it is single. With pigmented skin, you see lower down, it is pigmented, and maybe 1, 2, or 3 lobules could be there. That is because of the growth of this malignant tumor. Lobulated distally, again I have told you. No visible pulsation, again inspection. A vessel which grows from the vessel, you may see the pulsations. So you would say, sir, no visible pulsation here. Distal edema, again, a very important size of a malignant. If you say there is distal edema, sensations, his foot drop, ask the patient to move the foot, do dorsiflexion, do plantar flexion. If he is not able to do the dorsiflexion or plantar flexion, it means the nerves are compromised. The tumor has invaded the nerve, and it's a very important sign of malignancy. So examiner will understand, yes, this boy is going right. So no visible pulsation, distal edema because of the pressure on the vessels. Wasting of the thigh, you see here at the same time when you measure the size of the thing, you can say wasting, whole of the thigh is wasted. Patient not moving the toes. So this is inspection. Ask the patient, ungaliyan hilaiye apni. So he will say not able to move or he will not move. So involving the nerve, there is a pressure on the nerve. And always start with inspection again. I am telling the candidate, the examinee, how to begin with after telling his diagnosis and then doing inspection. And inspection is always followed by palpation. So palpation means you confirm the findings of inspection. So that's palpation. You use huge tumor, you find it is wasting, you feel the margins are ill-defined, but here it could be defined, but this could be a furrow because of the leg. Here it could be defined, but at places it is ill-defined. So always look for, beside the attitude, look for the local temperature. It's warm or it's raised, not halfway, in a very coordinated manner, in a very proper order. Local temperature is followed by tenderness. Tenderness is present in which area? Look for, sir, at this point, at this centimeter, at mediolateral border, at lower end, at the upper end, or in the middle. So these points are tender, and you see the face, eyes of the child or the patient. Feel for margins, confirm it is ill-defined or where it is well-defined. That's again very important, very gently, because this is a huge mass. Consistency, variegated. It can be bony hard at places, it can be soft at places, it can be fluctuant also because of the necrosis. Measurements now you take truly what you look for on inspection. Take your tape measure and take the diameter, take the length above downwards, and take the other measurements whichever are visible to you. Confirm your finding which you observed on inspection. See the surface, feel, is it lobulated or smooth or rough? So whatever you feel like. In a benign tumor, it may be very smooth, like the osteochondroma. So here you find what type of surface is it, what is the texture, I should say. You can feel the pulsations. Yes, it is pulsatile, not difficult. Say yes or no. Edema, whether it is pitting, see the shin and the anteromedial border of the tibia, you can find pitting edema. See the ankle region, which are bony prominences. It's a very important part of the palpation. Posterior tibial artery vessels must always be palpated. Please be clear. Vessels should always be palpated. Look for posterior tibial artery. It may be decreased in volume or may be absent, may be engulfed by the tumor. The distal part can become gangrenous, though edema is very consistently commonly seen in malignant tumors like osteosarcoma. Look for sensations also, L5, S1, and all other dermatomes you should look for. Motor function of the foot, again, should be tested. See the power, see the involvement. Lymph nodes, don't forget. Always examine the regional lymph nodes. Sarcomas spread by blood. Remember, carcinoma spread by lymph nodes. You may not come across lymph nodes regional in inguinalogy in these patients. But if it is infected, if it is ulcerated, then look for lymph nodes. Always keep differentiation. I have missed one slide. There could be ulceration. Or maybe that comes later on. That is again a very important sign of malignant tumors or osteosarcoma. These patients can bleed and you may have to give a kind of a little bit of pressure bandage. So rupture or a break in the continuity of skin, formation of ulcers, sometimes fungating masses we have seen in long duration cases, are main important sign of malignancy, and osteosarcoma is very well presenting these patients with break-in of the skin. Examiner can ask you, what are the other possibilities? Okay, it could be malignancy, it is a malignant growth, and maybe it is osteosarcoma. But what is the second possibility? What are the other possibilities you will keep in mind? Because what you have seen and what you have palpated doesn't mean it's always a osteosarcoma or an entity which you are keeping in mind. You have to confirm the diagnosis, and before that, you have to make a differential diagnosis. So what is differential diagnosis? What are other possibilities? And don't forget acute osteomyelitis. My teacher, Mani Professor, always used to say that osteomyelitis can present in any form like tuberculosis, and tuberculosis or tumor can present in any form. So acute osteomyelitis or chronic osteomyelitis, or it could be a secondary tumor also, you should always keep a possibility in examination. Maybe I would say as number one differential diagnosis. And myositis ossificans when the surface is hard, particularly in the region of vastus medialis in paraplegics and other patients when patients undergoes massage. Or a tumor can also grow over the myositis ossificans. So myositis ossificans again is a very important differential diagnosis. Please keep in mind. What are you going to do now? That's the next question. Once the candidate has told his differential diagnosis and the examiner feels satisfied, okay, what are you going to do now? That means you have to tell about the investigations to confirm what you have thought over it and what you consider that this patient could be suffering from a malignant tumor or an osteomyelitis or a myositis ossificans. And the most important investigation the candidate forgets in the examination. The whole life he's seeing the x-rays, but in examination maybe he's fed the diagnosis, he will never say x-rays. So x-ray is the most important investigation in orthopedics, and that is again very important investigation for a tumor. X-ray of the part, you say, sir, I will do the x-rays of this patient. So plain x-rays is very important, very, very important. And you are to lead the examiner, you have to guide the examiner what type of questions he should actually ask you. You should be very clever. An examiner should be very intelligent. He should be asking him, he should be expecting leading questions from him. So he has to guide the examiner. So plain x-rays, he will say, no, it is an osteoblastic type of osteosarcoma. I'm told that the cases are being presented in the form of x-rays also. It's an osteoblastic type of osteosarcoma. Siglosing type, you see it is siglosing type. It's all around white in the distal end of the femur. More posteriorly, some anteriorly, and here also, medially also. This is the osteoblastic type of osteosarcoma, which you will read on the x-rays. See here, telangiectatic type. Again, a very important variety with almost bone node picture as you find here. That is the other case. It is permeative type of bone destruction, and you find here the lytic, the lysis here, the lytic here, again the lysis here, and osteoid is growing into the soft tissues. That is the osteoid. The tumor cells, the malignant cells are growing, are forming, laying down directly the malignant bone or the osteoid in the soft tissues. So that is the telangiectatic type of osteogenic sarcoma. And here you find diaphyseal osteosarcoma. It is not always that you see osteosarcoma at the metaphyseal end. You can see at the diaphysis also. Same is true of Ewing sarcoma. That is diaphyseal, but you can also see in the metaphyseal region or metaphysio-diaphyseal region as for the Ewing sarcoma is concerned. So here it is a diaphyseal type of osteosarcoma. You see on the posteromedial side, intramedullary here also, and newborn formation in the soft tissues. You find here, this is the newborn formation in the soft tissues. This is shoulder, the upper end of the humerus, I should say. The sun ray type of appearance, the classical one. The Codman triangle. The Codman triangle is a radiological finding in so many conditions. Don't say it is a definite sign of osteosarcoma. No, it is just that the osteosarcoma is lifted by the tumor cells and osteoid is laid down here. So you can read that this is the Codman's triangle, an important sign, I should say, and can be seen in other conditions also. The sun ray appearance of the proximal end of the humerus. See the lysis also. Yes, examiner will say, okay, you have done X-rays. What else you do now? He is coming on the management. How are you going to manage this case? A very important part in the end of his viva, the candidate is facing. And again, he should be very intelligent. He should not forget the most important investigation after X-rays of the part, that is X-rays of the chest. X-rays of the chest, a very important investigation to look for metastasis. Don't forget, I'm emphasizing it again and again. So X-ray chest is again a very important investigations, but X-ray chest may not show you findings all the times. So here you find these are the nodules, plain X-ray of the patient of osteosarcoma, showing multiple metastatic nodules. At times they can be calcified also. Classical finding in osteosarcoma. You may fail to see also. You may ask for CT examination. So CT, MR, positron is a very important investigation these days. I don't know whether it's being done in Gangaram or not, but recently at Rohtak, the people have come and they have installed this machine. And I just talked to a lady, Dr. Praveen Kundu. Yes, what are the advantages of PET scan? And she told me that in a single investigation, you can look for occult metastasis, distant metastasis, and you can also see the chest. So it has a better sensitivity and specificity and a better investigation as far as the identification of occult metastasis or distant metastasis or distant spread and X-ray chest metastasis can be seen in a single investigations. You don't have to do a CT scan separately because CT is an essential component of this PET. And these days again we are going to get MR PET. MR PET we are going to get shortly, where you can see the soft tissues also. CT covers most of the bony part also, but MR will cover the soft tissue part. So that way PET scan or a positron emission type of a investigation is very important. Bone scan, you see. Bone scan is better in a sclerotic type of tumor or a metastasis. In a lytic type of a tumor, the positron emission is very important. Again, that is the advantages and disadvantages of the two investigations. So bone scan, you may not find the hot areas in different part of the body, but since you do from skull to toes in PT, in PET scan, so different metastasis involvement of various organs can be very well identified and investigated with single investigation. Again, these are the advantages of this PET scan. The candidates and the examinees must know, very important investigation. You see again on CT section, but you can also see the colored areas on PET. This is a CT scan. You find the nodules. This is bone scan, hot areas. You do it with technetium 99. The examiner can ask you a question. I'm just covering up the topic partly more because everything cannot be covered on the case itself. I'm discussing part of the theory, which because this is a virtual a kind of a webinar or a seminar. So I'm asking question, you could say, or I am dictating, or I am making we all people, including myself, wise as I learn from my colleagues also. And you find here the soft tissue extension. You see here the growth into the soft tissues. And you see MRI again has an advantage. Well, one can ask you a question that it is not cross the growth plate. So this is the tumor mass that is the soft tissue, and it tells us that it has not crossed the growth plate. So that's again a very important investigation. You cannot cover the whole of the femur with MR, but with PET you can cover. Again, you find the extent of the tumor. You can decide the level of your resection. You can see what is the relationship of the tumor mass with the vessels. So this is a vessel, and this is abutting. The tumor is abutting the vessel, which you can very well see on MR and not on CT or X-rays. And that is a very important cause of feeble pulsation or distal edema. And your decision that once the vessel is involved with the tumor, so you have to do a procedure wherein the vessel has to be taken with this tumor. You have to ligate it, and you have to define the upper end and the lower end, and whether you will be able to save the limb or not, or the patient is going to land up into amputation. Again, these are very important in investigations in deciding the line of action, that where you should act and what kind of surgical intervention you should do. Biopsy, now say, no, okay, sir. The last question examiner will ask, okay, now we think it is going more in favor of a tumor, a malignant tumor, osteosarcoma. So what are you going to do now? And the candidate must answer, sir, I will do biopsy. That is the confirmatory. That is the gold standard. Histopathology is the most important investigation to arrive at a diagnosis. If you have not taken a decision based on biopsy and taken a decision otherwise, it's criminal. Medical legal issues come up, and so many colleagues of ours have suffered. So don't forget that, sir, I will confirm the diagnosis on biopsy, and then you will decide what you are going to do. And here your 95% of your viva is over as far as this short case is concerned. And every candidate is going to be asked a different question, of course, 10%, 20%, but 80% or 90%, the question remains the same. So I'm not going to talk on this, how to take this biopsy. And I think I have taken more of your time as far as the short case presentation is concerned. You see here, this is a fungating mass here, and bandage has been applied. It can bleed anytime. This patient died. His father was adamant. There is history of trauma. He thought the teacher, a school teacher, hit this child with a stick, and cancer is developed because of that. Generally, such issues you come up, the postgraduates and the residents come up when they take history, and he was adamant, no, I will have claim from this schoolmaster because he was beating my children every day, and it is because of the stick that this cancer is there. And we had to convince him that it is not because of the stick. But generally, history of trauma can be there in all such patients, and candidate should be aware that this cannot be caused by a stick. Must remember pathological fracture. When there is lysis, there can be more deformities, loss of transmitted movements, but that would depend upon the type and size of the tumor. So pathological fracture, again, a very important sequelae and finding in malignant tumors like osteogenic sarcoma. This child too had. See, look for ulceration, fungating masses, bleeding, pressure bandages on. You should not try to remove, or be gentle while doing examination. examiners are observing the examinees, please be careful. This is an amputated part, just a specimen showing you, and it is begun. I think I have a second part also. If you say I can go on management, if you say the next speaker may be requested to
Sir, you can go on management, sir.
little bit of management, I would say.
Yeah, please.
So examiner can ask you a question, what is neoadjuvant chemotherapy? So a therapy which is done prior to the main treatment to reduce the size of tumor is called as a neoadjuvant chemotherapy. And what is adjuvant therapy? Which is done after the surgical intervention is done to kill the remaining cancer cells or the malignant cells. The two definitions you should be well versed as far as this presentation is concerned. So there's adjuvant chemotherapy. Resection means that soft tissue coverage normal with skin you should take with it liberally and send that part which looks normal also for histopathological examination that is not carrying any cancer cells as far as the prognosis is concerned. Please be remember. So this is tumor as a whole with myofascial involvement and a normal tissue around it should be taken. That's very important. That is it. Okay. You can do reconstruction also. You should look for biological procedures because patients are very poor. When you use prosthesis, when you do prosthesis, mega prosthesis, not for laborers, for gentle workers, for sedentary workers. So these are again, the limb salvage going more and more in favor because nobody likes amputation. So earlier presentation, battery it is, see the levels of the tumor 6 centimeter above, you can go for amputation also, or you can go for resection, or you can go for mega prosthesis insertion. Like here you find that is the mega process after excision of the tumor, resection of the tumor. You can go for biological procedure like epilization of fibula. These cases are done by Dr. Zilesing. I'm grateful to him. He gave me some of his slides. And you see this whole of tumor has been excised. This is a cement, all cement spacer with a rod to give stability. Innovation, cement spacer with a rod in osteosarcoma of the proximal humerus. He has written a paper also, and that's the cement spacer. Good function till metastasis appear. 42 to 65% of fiber survival rate has been reported in these patients. Arthrodesis is again a very important after doing resection. You find here, yeah, that's the tumor. That's the tumor with soft tissue around it with myofascial group, and that's the spacer. That case I showed you earlier. Here the same, and rotation plasty. You see, excise the tumor with the joint and take the ankle and put the ankle here. It may look ugly, save nerve and vessels, and that is the resected part, and take this tibia fibula up. So the ankle may come down, and that may work as a knee joint. You find here, this is ankle, the tibia and fibula are fused to the distal femur after excision. That's the femur, and that's the tibia. So limb will become short, and then you can give extended prosthesis. You find here, nerves and vessels are saved. The tumor has been excised. On MR, we confirm that the tumor is, the vessels can be isolated. They are vessels far away from the tumor. So you can do arthrodesis between the two ends of the healthy bones. That is turnplasty or arthrodesis resection, rotation plasty, I should say. And I think I have covered enough. Partly biological procedure I have told you, the mega process I have told you, and I have talked to you on the various aspects of this presentation, starting how it is malignant, age, size, site, shape, proliferation, rapidly growing. And here you see again, this tumor has been excised. That is MR. You see the end of the tumor you can see here. That is the resected part, 6 centimeter above. You can measure the size. And here, fibula we have taken. and fused here with the distal end of the tibia. So here hypertrophy. See the hypertrophy of the fibula, which has been done as a Huntington procedure, single stage, and limb is saved. So that is
But
12.
your
And I
slide
thank
is not visible.
pardon, sir. Oh, I just
Your
forget it.
slide is not visible actually.
Oh, I'm sorry. I
Yes,
forgot to put it on the full scale. So that is
okay.
here again a diaphyseal tumor that is excised, and that is a stabilization of the fibula, and see the hypertrophy after section of the tumor. And nobody reminded me also, Professor Ray. I'm sorry for that. I just could not put on the full
No,
theme.
I thought.
I'm sorry for that. So it is difficult to revise now. The procedure
No, it's okay. Okay.
effective.
Whatever you have said.
And here you see this is the bone and the nail starting from the trochanter going in the tibia after resection, and the bone has been orthodized. A very important procedure to preserve the limb. And with this, I thank you for the invitation to Professor Rajgopalan, Professor Ray, and IOA, the ministry, and secretaries, and EC, and everybody. And thank you very much.
Thank you, Professor Maggu, for such a elaborate and nice presentation. Now, I first come to Dr. Harsha Shah. Your comments or any questions for Dr. Maggu?
Well, thanks, Dr. Manish. I think I should not have been the first fellow to give comments to Dr. Maggu's lecture. Excellent lecture. I think all the PGs, if they listen to this, how not to fail more than how to pass is what he has told everything in detail. I know it's very difficult to cover up everything in tumor sessions of this kind in a short time. Sir, excellent, sir. I learned a lot from you just now, and I think all the PGs will be very happy with it. The only thing that has probably been missing is probably the investigation part, where you said that we start with X-rays, and you taught the student to lead the examiner, not to go to places where they do not know, like blood urine test and other biochemical test and all that, which are probably a little difficult for everyone. Otherwise, I think that was an excellent guidelines from you for teaching. And as per your stature, you have also chosen the tumor of such a large extent that things should be very easy for PGs to pass. But if you bring a tumor which is little smaller and this one, then the differential diagnosis and confusion will be more for the postgraduate. We rarely get such huge tumors. Not that in India we don't get, but still.
That was the first one.
I think
I have
all
shown
in all, it was very, very nice and a good experience to listen to you again, sir. Thank you so much.
Thank you, Professor Harshad.
I will beg your pardon, Professor Rajgopalan and faculty. Please, actually, I was committed somewhere else because this was postponed so many times. You will please excuse me. I had to leave.
Manish, please welcome Dr. Das.
Dr.
Manish?
Das, good evening. Dr. Das, good evening. And Dr.
Good
Das,
evening.
please be ready with your presentation because you are the next one. Okay.
On the
Dr. Raju, unfortunately, is not well. So we will take Dr. Das as the next one. So I come to Professor M.M. Ray. Sir, your comments or questions for Dr. Maggu?
No, after, thank you. After presentation of Dr. Magu, I have nothing to say. I have seen him as teacher, as examiner many times for many, many years since. So, and I think what his presentation is more than enough for the PG. It is enough. And exactly what we asked in the exam, Professor Harshad will agree with me that exactly that we asked in the examination. And but only think a few things that my observation is that in huge tumor, aggressive tumor, as Professor Magu has shown in one case, there might be some skin necrosis on inspection. Might be the examiner examining might sometimes come across with the skin necrosis and fungal, whatever he has mentioned also. That is one part. And about differential diagnosis, Ewing's tumor, Ewing's sarcoma should come also. I think so, isn't it? Ewing's tumor. And one more, sir, I would request Professor Magu to say a few words about the Codman's triangle. If we take biopsy from Codman's triangle. My needle goes to Codman's triangle. What tissue will come? Should it come represent the tumor tissue or any other tissue?
Dr. Maggu, please.
Dr. Maggu,
I think
you-
Dr. Maggu, I think he has left. Or no, Dr. Maggu, can you hear us? Can you answer Dr. Ray's question?
he's
His photo has become still.
Dr. Maggu.
I think he's muted. I don't know, but I don't see the mute sign. Yeah, he's muted.
Sir, Dr. Maggu, please unmute yourself. Dr. Maggu, we can't hear you.
I think we go ahead. The answer for the thing what he asked is the Codman's triangle is only a reparative bone from the periosteum. It does not represent the tumor tissue. And Dr. Margo already said it's a non-specific one. It can be in fractures, healing, it can be in osteomyelitis. So it's not an area where you should take the biopsy from. It is
yeah.
only contains normal bone, not tumor bone.
Okay.
I think Dr. Margo is also off the screen.
Yeah, Dr. Das, your comments or any questions? The whole faculty can take it. Dr. Das, we can't hear you. Please
Unmute.
He's also muted.
Muted.
Dr. Das, please unmute yourself.
Dr. Das,
Dr.
unmute.
Das, we can't hear you. Please unmute yourself.
Sir, okay, he's unmuted. Yes, sir. Please carry on.
Right. From the very beginning, each and every step was covered by Dr. Maggu in an excellent way. And I do personally believe that it will help all the postgraduate trainee regarding the different aspects of this important topic. And more or less, there is no stone leaves unturned regarding this issue. So for this session, he did an excellent job, and I really thanks him.
Thank you, Professor Das. And Dr. Brijesh Nandan, your comments or questions?
Sir, it was a nice presentation as far as postgraduate examinee is concerned. And I think it's a very detailed and complete presentation for short case, even for the long case.
Okay. So, yes, Dr. Harshad.
Question?
Yes, sir.
Yes, all tumors have some chemical markers.
Yeah.
There are so many that it's very difficult for me itself to remember all of them. Can somebody simplify on that with respect to this particular case? This is okay. It may be straightforward from clinical point of view or biopsy, but when it comes to a smaller tumor and you want to have some more clinical markers, some blood test, urine test, and other things like ESR routine things, all right. But then
I think I'll
Yeah,
give this
in
question
case-
to Dr. Brijesh.
Yeah, in case of osteosarcoma, as far as immunohistochemistry is concerned, there is no such a diagnostic marker. Yes, there is a prognostic marker is there. There is a study by a Tumor Institute in Italy, and that paper was published in 2009, which shows if the alkaline phosphatase or acid phosphatase is more than 75 and alkaline is more than 600, then it is a poor prognostic sign for osteosarcoma. If it is less than 600, then it has a good prognostic sign. This is the only chemical marker which is proved and published in papers.
Okay. Any other comment?
to differential diagnosis, what kind of test do we ask for? Now, this tumor was a huge tumor.
Yeah.
Okay, you decided the fate of the patient and the limb. But when it comes to a smaller tumor, where you may have many differential diagnoses.
So, as far as bone tumor is concerned, the differential diagnosis, we can make a differential only by X-ray. I think still orthopedic oncology or bone tumor is one thing where X-ray is the most relevant investigation. So by MRI, CT scan, it can give more clarity into the pathology, that particular pathology. But as far as DD is concerned, X-ray is the only investigation.
No, that's okay. You do an X-ray, you do an MRI, you do a PET scan. But then for confirmation of diagnosis, you have the biopsy also. But
Sure.
on protocol, when you ask for investigations,
Dr. Shah, please.
when you ask for investigations, when there is a differential diagnosis,
Dr. Shah,
what all investigations of blood, urine, and other things that you want to ask other than this radiological?
Yeah, you are talking about a serum investigation or radiological investigations?
No, not the radiological part of it. That part of it has been covered. I'm talking about blood urine test and other immunochemistry, etc.
Look, sir, on blood investigation, there are only three things which is important. First is the level of alkaline phosphatase. Second is the level of serum calcium. That is important in case of metastatic osteosarcoma. In localized osteosarcoma, even the level of serum calcium has no value. So as far as prognostication is concerned, if we have to prognosticate, serum acid phosphatase and alkaline phosphatase has importance. But as far as diagnosis is concerned, it is not important. No, not even a single investigation which is important in osteosarcoma for diagnostic purpose.
No, there's one group of drugs, I mean, not drugs, I'm sorry, tumors,
Shah,
which is known
Shah.
as secondary.
Yeah, I think you're going away from what we
No,
want for the post-graduation.
Yeah.
So it's only osteosarcoma. I think we should.
For postgraduates only, suppose you are getting the similar secondary tumor swelling.
Okay. Yeah.
It can be prostatic. It can be breast cancer. It can be GIT. So you do have certain.
Yeah, that's
it. That's what I was asking for.
So, that is a different workup. That workup is for metastatic bone disease. It includes all the markers like CES, CA125, PSA.
So few markers which the postgraduates are supposed to know. That's all I wanted to know.
Yeah.
I do not know any one of them because we have oncological surgeons like you. Here, two of them, we send all of them there and then this goes out of our mind. So guidelines, or we can discuss this after all the presentations are over.
Yeah, thank you, sir.
I think we'll go to the next presentation by Dr. Rajgopalan. You have any comments, or we can go ahead?
No, we go to the next speaker, Dr. Das.
Dr. Das, please share your screen. And I'll be just leaving for 15-20 minutes. So if Dr. Rajgopalan is not there, then Dr. Harsha Shah take over. I'll be soon back, sir.
Okay.
I take over for what?
I have to go to meet someone. I'll just come in 15-20 minutes. Okay.
I'll be there. Don't worry. If I'm not there, Dr. Ray is there. Dr. Shah is there. No problem.
I will be
I think Dr. Ray is more senior.
No problem, Dr. Ray. Dr. Ray already informed me that he has some problem at 7. So Shah, if I'm not there, you take over. But I think I'll be there.
I have another meeting actually of my classmates.
No problem, sir. You carry on.
I will be there, but the program which is there is not in front of me.
Ravi will send you.
Dr. Ravi Chauhan will help. Fine, no problem.
Okay, Dr. Das, please continue.
Good evening, everybody. Today's topics was osteosarcoma, the Ewing sarcoma, and giant cell tumor, enchondroma, and exostosis. And apart from my topic, each and every topic presents with swelling. So for the postgraduate students, they should examine the case as if they are examining a swelling, maintaining each and every aspects of it. Say, for example, the inspection findings, the palpation, measurement, and all this. But if we consider the enchondroma, it has two types of presentation. One is solitary and another is multiple. The solitary enchondroma is a relatively common, and multiple enchondromatosis is extremely rare. So in solitary enchondroma, if we just clinically examine, in majority of the cases, there is no symptoms. And usually the patient presents whenever there is some pathological fracture, or in majority of the cases, it is just coincidental findings. For any other reasons, if we get an X-ray done, there is a lesion, osteolytic lesion inside the bone is visible. So for the postgraduate students, I do believe that initially I should give some informations regarding this benign tumor, and then we present the cases and we should discuss how to tackle this. If you consider the origin of this tumor, there are two probabilities or opinion. One is that it is from unremodeled epiphyseal growth cartilage persisting in the physis. So whenever the growth is there, and this cartilage also grows. And another opinion is the persistence of original cartilaginous anlage of the bone. And there are two types, solitary and multiple, and it is benign in nature, and majority are latent. Resultant effect is there is actually no clinical manifestation in most of the cases, and only if there is an injury and pathological trivial injury with a pathological fracture, they present like that way, or due to some any other cause, they present as a concomitant finding. And most commonly, it occurs in the first and second decades, and there is a male preponderance. And 11% of the total benign bone tumors belongs to this variety, and of which 40% are in the bones of the hands and feet, usually phalanx. The femur and proximal humerus are the other common sites of this tumor. And presentations are two forms, which I have mentioned already, is a pathological fracture through a lesion in the phalanx, because it is the most exposed part, and incidental finding on a radiograph taken for other reasons. And how to diagnose it? Whenever it is asymptomatic, there is no question of diagnosis, because we do not know this lesion is persisting in the bone. But if the patient has some trivial injury following which pain and get an X-ray done, and that shows a lytic lesion in the bone, then we think about there is a possibility of enchondroma. And if we go through the radiology, then there are certain characteristics in the radiological finding of this lesion. It is classically located in the metaphyseal lesion, and it is central in nature in the medullary cavity. Bone may be wider, but if you consider why the bone is wide, this is not due to expansion of the swelling, but it is due to remodeling defect on the metaphyseal region. And in pediatric age group patient, it is radiolucent, but as age advances, there is some degenerative changes, and ultimately there is some intralesional calcification at later stage. And usually there is no periosteal reaction. These are some of the examples. On my left-hand side, if you consider there's a huge lesion, that means it is an active lesion. It is not silent, and it presents with pathological fracture. In the middle portion, there is involvement of the terminal phalanx of the thumb. And if you consider the right side, there is involvement of the middle phalanx. And in the central picture, you see the patient is of 39 years age, and there is multiple calcified lesions. That means there is calcification of the cartilage. And MRI is not required in majority of the cases for diagnosing this tumor, but it has certain specificity. The cartilaginous matrix has intermediate signal intensity of T1 weighted image, and it has high signal intensity on T2 weighted image. And it has sharp margin with adjacent bone, and there is no involvement of the soft tissues, and there is no peripheral edema. And like other tumor, there is need for histopathological examination for confirmation of the tumor. But if you consider the enchondroma, no preoperative biopsy is necessary. And incisional biopsy is usually contraindicated. Why? The reason behind, if you get an incisional biopsy of such a small lesion, if it is in the phalanx, say for example, then there is some changes inside the tumorous tissues. And subsequently, if you get an histopathological examination done, then that will give us wrong information regarding the exact nature of the lesion. So if at all we have to go for biopsy, that should be incisional biopsy, and as a whole, the whole of the tumor to be removed. And otherwise, the preoperative biopsy has no role in this tumor. But if we consider the multiple enchondromatosis, the multiple enchondromatosis there are two varieties. One is Ollier disease, and these are relatively rare, and very rarely we see this type of problems, but it has certain importance and it has some clinical presentations. There are multiple deformities of the different parts according to their involvement, and it was described as early as 1800. Yes, and bilateral involvement with unilateral predominance is a characteristics of this lesion, and it leads to growth deformities, limb length disparity, and angular deformation. One thing is important: whenever there is angular deformation, if we go for corrective osteotomy, then we should not pay any regards to the enchondroma bearing part, because for correction, whichever level is needed for osteotomy, and that level should be selected, whether it contains the tumor or not is not a consideration in this case. On the other hand, another important point regarding multiple enchondromatosis is this: they are more prone to secondary chondrosarcomatous changes, and the incidence is as high as 25%. And pelvis and shoulder girdles are the common locations which usually subsequently turns into secondary chondrosarcomatous change. And of course, this is not of my patient. I have taken this from a textbook. And if you see this picture, you will find there is involvement of the forearm bones with deformity of the wrist, and simultaneously there is involvement of the phalanges with some deformity of the hands. And these are the radiological findings. You see in the wrist, the deformity is so much and it needs the corrective surgery. Otherwise, there will be functional loss. And another variety of multiple enchondromatosis is Maffucci disease. The Maffucci disease is much more severe than this condition, and it is associated with multiple soft tissue hemangioma, and it has further more risk of malignant transformation in later life. And this may be the presentation of Maffucci disease, and whenever it is seriously involved, there's a functional loss of the affected part is tremendous. Now, with these facts and in our mind, we should proceed for this tumor. And I'm just coming back later on, and I'm proceeding to this. This is a case 1, and the patient, aged 39 years, had a trivial injury, and he had some pain in the ring finger. And whenever the X-ray was done, and it showed there is a lytic lesion with pathological fracture in the middle phalanx, and it was treated conservatively, and within 4 weeks' time, the fracture had united, and there was no functional disability, and full mobility of the hand was there. And this is another case which needed intervention. The boy was 7 years at the time of presentation. There was some swelling and aching pain in the second metacarpal bone area, and radiologically, this is basically expansion is there. And one thing I had mentioned, this expansion of the bone or thickening of the bone or broadening of the bone is not due to, in true sense, expansion of the tumor tissue, but it is mainly due to remodeling defect of the metaphyseal region. And as because almost whole of the bone was involved, so this is basically an active variety, and the patient presents with some aching pain. So I decided to thorough curettage and bone grafting. And after 6 months, there was some recurrence at different spots. And in these conditions, it was recurated, but no bone grafting was done on the second operative instance. And if you see on the right-hand picture, and after 2 years, there is no evidences of recurrence. And not only this, the size and shape of the second metacarpal bone is almost normal. And this is the functional ability of the hand, and there is no functional deficiency. So if we consider all these points, so for the treatment of this condition, in majority of the lesions do not require active intervention. Only we have to observe and clinically assess along with the radiological investigations at regular intervals. Say, for example, there is an accidental detection of a lytic lesion in the phalanx. So what should we do? We first clinically assess whether the swelling is a palpable swelling or not. In majority of the cases, this is not palpable swelling. And we should clinically assess whether the size is increasing in size or not. And secondly, we should get an X-ray done to find the size of the swelling is increasing or not. Initially, it is after 6 weeks, and thereafter at an interval of 3 to 6 months, at least for 2 years. If up to 2 years, there is no alteration of the size of the swelling and simultaneously there is no symptoms, then we can safely consider that there is no need for further treatment. On the other hand, if it is a symptom producing, then there is need for operative management in the form of curettage. If the lesion is big, there is need for bone grafting. Otherwise, thorough curettage is good enough for managing this case. Only in certain conditions, whenever there is multiple enchondromatosis with deformations, it needs specific treatment for improvement of the functional ability of the affected part of the body. Or if there is sarcomatous changes, which is indicated both clinically and investigation wise, and that is by nature chondrosarcomatous change, and like a treatment of chondrosarcoma, we should treat it. Thank you.
Very, very nice. Can we, Dr. Lalit is there?
Yes, I'm there.
Lalit, can you take over?
Yes, very nice presentation, very crisp and clear. And for postgraduate students, I think enchondroma can meet them in the exam in various forms. It can come as a short case, not very common, but it can come as a short question, and it can definitely come as a X-ray in the table viva. So this would be a common X-ray in the table viva and a short note in the theory exam. You should also be aware that enchondroma now also would become a part of the OSCE questions. So this will be another favorite OSCE where different aspects of enchondroma could be asked. So for the students, I think they need to understand the presentation, the common presentations, both clinical as well as radiological. And I think they have been covered very well in this talk. Dr. Rajgopalan, back to you.
Yeah, I think so. I mean, Lalit has actually same thing. It's not, we don't get it so many to sometimes keep in the practical exam. But this is to the students. Even if you don't get a case of enchondroma, examiner will take you there in the differential diagnosis, and you should know. And it's quite often a question in the theory exam, and was very well covered by sir. Anybody else want to make any comments? Shah, any comments?
No, it was excellent. I think he's covered everything. There's nothing more to it. Probably only thing is the differential diagnosis. When you see an X-ray with a swelling, there are so many varieties of differential diagnosis which can be enumerated. And probably Dr. Das can say a few more. So
Right.
the student will know how to think in those directions, other than enchondroma and
Right.
this one.
Whenever
From
this type of
tuberculosis,
lytic lesion is
from
there,
tuberculosis, tuberculodactylitis, even a trauma, lytic lesion has some 30, 40 differential diagnoses. I know it's very difficult, but still, when it comes to the short bones of the hand, they're more specific, isn't it?
Thank you, Dr. Shah. Over to you, Dr. Das.
in majority of the cases, if you get this type of lytic lesion, and if it is a classical one, that means margins are well delineated, it is a central lesion, then radiological diagnosis is more or less confirmed. This is a case of enchondroma. But if it
In
is
spite of that, differential diagnosis is asked for.
no, if it is a expanding lesion, then there are several other possibilities, or it is a expansile lesions. That means, though rare, the giant cell tumor of the phalanx may be, if it is an expansion is there. And in our country, in certain cases, the tuberculosis may present like this way, in the lytic lesion in the phalanx. Though the classical radiological picture of spina ventosa, or the involvement of the phalanx or the metacarpals or the metatarsals by tuberculosis, is not a classical lytic, but in my experience, I have found at least on 5 occasions the tuberculosis of the phalanx with the lytic lesions which mimics the enchondroma. Or if there is a widespread involvement, which we can say it is a case of the active variety of enchondroma, and the fibrous dysplasia of the phalanx may be, though these conditions are very rare. But if there is a phalangeal lesion well circumscribed, then the radiological diagnosis should be enchondroma.
Thank you,
Can
sir.
I add something?
Dr. Brajesh, Dr. Brajesh, will you add?
Tuberculosis and osteomyelitis, if
Dr. Shah, just wait. Dr. Brajesh.
Yeah.
Pardon?
Sir, as
Just
far
wait,
as
Dr. Shah. Dr. Brajesh will finish and then I'll come to you.
Yeah.
Sir, as far as differential diagnosis of enchondroma is concerned, enchondroma of short bones, the first DD should be tuberculodactylitis. Now, enchondroma of long bones. Enchondroma of long bones, the commonest DD is either a bone infarct or a well-differentiated chondrosarcoma, because radiologically you can't differentiate between a well-differentiated chondrosarcoma with enchondroma. Both are present with a comma-shaped flocculent ossifications.
Thank you, Dr. Brajesh. Hey, Dr. Shah, please carry on. Dr. Shah? Harshad Shah. Dr. Shah, please.
Yes. No, what I was thinking was, for these things, tuberculosis and chronic osteomyelitis, if these two things are put in, probably the student must pass. Then you can give the rarer things if you know. This is what was in my mind most of the time.
Yeah, sure, sir.
I don't know if you have anything more common.
Brajesh,
Lalit wants to say something.
Lalit, please.
So this is a favorite area in the exam, especially when you get a lytic lesion on the X-ray viva. So I tell my students that remind yourself of giant cell variants. So that will immediately give you 10 answers in your question, and then you can start fitting which can be more common than not. Because in the exam you fall short of names. In tumors, you suddenly forget the names. You start thinking in the same way, like 2 fibrous lesions, 2 cartilage lesions, and remind yourself. So giant cell variants is a big savior, that category of enlisted ones, to help you giving a differential diagnosis.
I think that's a very good answer.
Yeah, that is one thing. That's actually, that is again said what I wanted to say. That is, whether you are writing a differential diagnosis in theory, whether you are talking about an X-ray, and whether you got a case is different. If your case is an osteochondroma, there is no DD for you, then there's no other DD. I mean, if this boy says enchondroma, he may get battered because there's nothing to support. But when you get an X-ray, a giant cell tumor itself is a DD. and all other variants. Theory, like you said, probably you have to write everything. I think that they should know. If they mismatch it, it'll be a problem.
Yeah.
Yeah, I'm
Manish,
back. I'm back. I'm back.
Manish, I think anything more? Ravi, anybody else I've forgotten? Who is, because the screen I cannot see anybody else.
What we can do, we can, call Dr. Brigesh's presentation, and then we can discuss it later on.
Fine. Okay. Okay.
At
fine.
the end, because we have to have an X-ray session also. Dr. Brijesh will.
Okay.
Okay.
Dr. Brijesh,
Yeah.
Manish, please take over.
Can I share my slide?
Yeah, sure.
Just a minute.
Rajesh, screen is not coming up.
Yeah, just a minute, sir.
Not able to see.
Just a minute, sir. And now it is visible, sir?
Yep.
Yeah, we can see that. Put it on the play mode, slide mode.
Sure.
Word, sir.
So I am presenting a case of osteochondroma. First, I will tell how to present a short case of osteochondroma and what are the possible questions that examiner can ask about osteochondroma. So osteochondroma are the common pathologies, and in most of the exam, you can see the case of osteochondroma. So now I'm presenting the case of osteochondroma. A 25-year-old male presented in outpatient department with the chief complaints of swelling over posterior thigh since 10 years. Swelling is insidious in onset, progressive in nature, and attained the present size. No history of sudden increase in size, not associated with pain or any other complaints. So these are the important points you should tell in the case of osteochondroma. No history of trauma, fever, any constitutional symptoms, no similar swelling in other part of body, no comorbidities, no history of any significant musculoskeletal problem, no history of single or multiple joint pains, no relevant family history. So on the basis of history, what is your diagnosis? If examiner asks, what is your diagnosis? So on the basis of history, it appears to be a benign bone or soft tissue swelling. Needs examination and investigations further. On general examination, no significant pallor, cyanosis, edema, regional lymphadenopathy noted. No signs of infection or any chronic disease. Cardiac and pulmonary evaluations are within normal limits. On inspection, there is a 16 into 20 centimeter size swelling over the posterior medial aspect of left proximal thigh, and surface is smooth, wide and safe. Skin over swelling is normal. No significant muscle wasting, no dilated veins. On palpation, local rise of temperature, no bony tenderness, well-defined margins. Swelling is hard in consistency, fixed to the femur. No reducible, not reducible or compressible, no fixity to the overlaying skin. No pulsations, no glue on auscultation, movements of knee joint, painless restriction of flexion beyond 100 degrees. No distal neurovascular deficit. So now the differential diagnosis: exostosis osteochondroma, periosteal chondromas, parosteal osteosarcoma, and myositis ossificans. So the first differential is osteochondroma because it's a painless swelling, no sudden history of increase in the size. Periosteal chondroma can be there. Parosteal osteosarcoma is least possible because there's no history of pain. There's no any other history of aggressive lesion, even on history or on examination. Myositis ossificans, no history of pain or inflammation at the initiation of swelling. Investigations are routine. And now come to the X-ray. This is the X-ray of the lesion, and X-ray shows the the most important part in short case presentation is the X-ray evaluation. So if you see the X-ray, you have to read this like the exophytic lesion noted in the medial and posterior cortex of left femur at metadiaphyseal junction away from the knee joint. Cortex and medulla of the lesion is continuous with that of the host bone. Asymmetric widening of metadiaphyseal junction. Evidence of cartilage cap noted. Impression osteochondroma of the femur as the X-ray is showing. So on X-ray, there can be the two questions. What is the diagnosis? Osteochondroma. What are the two basic shapes of the lesion on radiology? There can be a sessile, which is a broad-based lesion, and there can be a pedunculated, which is a lesion with a stalk. Now, this is the CT scan. CT scan, what you can see on the CT scan, a large bilobed exostosis arises from the posterior medial aspect of distal femur, diaphysis extending into the metaphyseal lesion, the medullary cavity of exostosis, which is an important point. The medullary cavity of exostosis is directly continuous with that of the femur, and although the cortex is thinned in several areas, it remains intact. So what are the questions examiner can ask after CT evaluation? What does CT add? In reality, in a lesion easily assessed on plain film, CT adds relatively little. In more difficult to image area like pelvis, scapula, spine, it can shed light on the relationship of mass to the underlying bone, showing continuity of to the medullary cavity. It is also able to assess for aggressive bony feature or large soft tissue component or presence of fracture. So this is the importance of CT if examiner is going to ask you. How should one assess the cartilage cap? Then CT is not an investigation of choice. MRI is the modality of choice to assess the cartilage as well as the surrounding soft tissue. Now come to the MRI. So this is a one-weighted axial section. So how do you read this MRI? As far as exam is concerned, examiner will not expect much from MRI, but you can give a basic detail on MRI. As in this case, there is a bilobed, two adjacent osteochondromas arising from the left posterior medial femur. A very thin cartilage cap is present, which is less than 5 millimeter, as it is always mentioned in the report. The medial component protrude into the vastus medialis adjacent to the septum between medial and posterior compartment. Impression on MRI, it looks like osteochondroma. Cartilage cap thickness is within normal limit as per reports. So, what question can arise after MRI? What thickness of cartilage is considered worrisome for malignant degeneration? Then it's approximately 1.5 centimeter thickness. A thinner is more assuring. Now come to the management. Excision of lesion. Why you need an excision? To rule out malignancy, to prevent complication, to confirm the diagnosis. So this is the case presentation part. Now, if you present a case of osteochondroma like this, so what are the more questions examiner can ask with you? So I am going one by one. First, point in favor of diagnosis. Young age, painless solitary growing, slowly growing bony swelling, close to the metaphysis and growing away from the joint. These are the points in favor of diagnosis. Other question, if there are more such swelling, what will be the diagnosis? The diagnosis would be the multiple hereditary exostosis, MHE. What is the other name of MHE? It is also known as a diaphyseal eclasia. So, what is the cause of swelling in osteochondromatosis or exostosis? It enlarges till the skeletal maturity and stops growing. Now come to another question. What can be the reason of sudden change in size or pain in the swelling in osteochondromas? Malignant transformation of osteochondroma can be the cause. Another question, what is the typical histopathological finding in osteochondromatosis? The typical microscopic finding section shows cartilage with mature bone trabeculae having bone marrow elements. Clinical feature of solitary and multiple solitary exostosis are similar? This is a common question examiner used to ask with a candidate. No, usually MHE is associated with the growth disturbances leading to short stature, deformed bone, and painful movements, which is not in the case of solitary exostosis. What are the different diagnostic radiographic feature of osteochondroma? A lesion at metaphysis, pedunculated or sessile growth, going away from the joint, medullary cavity of lesion is continuous with the medullary cavity of bone, and cortex of the lesion is continuous with the cortex of bone. Now, how to confirm the diagnosis? The diagnosis is confirmed by biopsy. Another question, how will you manage this patient? Since the swelling is causing blockage of knee flexion, it needs complete extra periosteal excision of swelling. It means that swelling should be completely excised with the rim of surrounding periosteum to prevent its recurrence and send the sample for histopathological examination. This should be your complete answer. Another question, should you treat all the patients with solitary exostosis? No, only symptomatic patients should be treated. Now, what are the indication of solitary osteochondroma excision? First is a mechanical block. Second, compression of neurovascular structure, which is common in case of proximal radial osteochondroma or proximal fibular osteochondromas, and painful swelling. Now, what can be the cause of pain in solitary osteochondromas? Bursa over cartilage cap can become inflamed. They can cause pain, compression of surrounding structures, and malignant transformation. Another question, which one, solitary MHE has more chances of malignant changes or MHEs? Multiple hereditary exostosis has higher incidence of malignant changes, which is documented as approximately 5 to 10% cases, and less than 1% case of solitary exostosis can convert into the malignant form of malignant changes like chondrosarcoma. Thank you. Can I stop sharing?
Yeah, you can stop. Thank you, Dr. Brijesh. I first come to Dr. Nilay Das. What are your comments or any questions for Dr. Brijesh? Dr. Das, you please unmute yourself.
Yes. Can you hear me?
Yes, sir.
Yes, sir.
This is one of the commonest tumor we encounter in our day-to-day practice, and for the students also, as because this is easily available in the short case, this is placed. So each and every postgraduate student should know every ins and outs of these clinical aspects of clinical entity. And for the presentation, and especially in cases of multiple hereditary exostosis, whenever there is involvement of the forearm bones, there is a cross-functional disability at times. The wrist functions and the ability to grip and the write and perform the finer activities are very problematic. So how these cases to be tackled, and they should know it, because the common cases are usually meant for undergraduate students. In our MBBS course, usually this is one of the common short case we place for. But whenever these type of cases to be selected as a short case in postgraduate examination, then apart from the conventional and common aspects, each and every postgraduate student should know about it. So I am requesting Brijesh to highlight on this point. And if there is any multiple hereditary exostosis associated with some functional disability of the wrist and deformation of the forearm, how they can be tackled.
Actually, sir, my case was osteochondromatosis, so I have not put more emphasis on MHE. In MHE, deformity corrections depends on that particular involved joint, and the functional disability. that the particular functional disability to which patient presented to us. So it depends on what kind of functional deformity you are talking about.
Dr. Das?
We can't hear you, sir.
Sir, please unmute yourself. Dr. Das, please unmute yourself. Dr. Das?
Yes. Can you
Yes,
hear
sir.
me?
Yes,
Yeah.
sir. Yes, sir.
Right.
Now we can hear you.
So whenever there is involvement of the radius and ulna, very often there is a deformation, the unnatural bowing of the radius, and there are rotational abnormalities are there. And apart from that, the grip strength is grossly diminished. And as a result of this, there is a functional disability. So it's a really challenge for each and every pediatric orthopedic surgeons if the patient presents with this type of deformation and functional disability. So I do personally believe as a postgraduate students, they must have some basic idea regarding this aspect.
Yes.
Okay. And now I come to Dr. Harshad. Your comments or questions for...
Yeah. Brajesh, this was very good. The majority of it was for the postgraduates to answer very well.
Thank you, sir.
Particularly, it is like asking, hey Siri, what is this? Hey Siri, what is that? I think we can ask Brajesh, hey Brajesh, what is this? Hey Brajesh, what is that? Question, answer, question, answer, question, answer. Most of them answered very well. I liked your presentation very well. It was very nice. And what Dr. Das has been emphasizing is, suppose you have an osteochondroma of the ulna, you get ulnar shortening, growth deformities, and then you get manus varus. So you have to correct the radial deformity, you have to lengthen the ulnar bone,
Sir,
or you have to bone graft,
frankly
those kind
speaking,
of things. All right, that all depends on individual things. Now here we are discussing about the osteochondroma, I'm sorry, all about the tumors. So with respect to tumors, this is this. One of my favorite questions is, what are the complications that you can have with this? It's a very simple question, but then you need to enumerate it. You have told all the complications throughout your lectures, but when you want to enumerate, a postgraduate tells one or two. So if you can tell them 1, 2, 3, 4, 5, 6, I think they should be very happy. It becomes the final answer for this, other than what all you have told.
Yeah, sir. That is a most common. If we go from commonest to least common,
from
the most common is a mechanical block. Second is a neurovascular complication. Third is an inflamed bursitis, and fourth is a malignant transformation.
Yeah, that is, I think, last. There is an injury. You can get a fracture of the neck in a style. This one, you can get infection of the bursa, inflammation and infection, and then that. So if you tell them these 4 or 5 complications, I think they'll be through. Thank you.
Yes.
Thank you, Dr. Harshad. Professor Mani, your comments or question for Dr. Brijesh?
Yes, Dr. Brijesh, very clear and crisp question answer session. I think that clarifies things better than any other way. Most of the things are answered, and one thing which at times students can miss is when the examiner asks them, what else have you examined? Have you examined other joints or not? So it is trying to emphasize whether they have looked for other swellings, and common areas would be opposite knee and bilateral shoulder. And all the time we keep reminding our students that also turn the patient around and look at the back. At times there is a scapular osteochondroma and it is glaring at your face, but you have missed it. So since, as Dr. Rajgopal said, there is no differential diagnosis in this case. So you have to be very careful and thorough in such a case, and maybe look for other bony swellings. And another important question which is asked is, why do you say it is arising from the bone? And suddenly the PG is thinking what to say. Obviously it is arising from the bone. So what is he asking me? So this is a standard question. So the postgraduate has to say that the consistency is bony hard, and as I follow the swelling towards the bone. It is in continuity with the bone. And the second question which is asked is, why do you say that there is a stalk to this? So you need to say that it is going away from the joint, and I can insinuate my fingers between the bony swelling and the main bone. So certain questions which need to be re-emphasized, and but I think an excellent talk, everything covered.
Thank you, Professor Mani. Dr. Ray, are you with us? Dr. Ray?
Dr. Ray left.
Okay. So I come to, for the final comments, I come to Professor Rajgopalan for your comments and questions.
Thank you, Manish. I think Dr. Rajesh had given a very nice presentation of the whole thing, and whatever has to be asked has been added by Shah, Dr. Das, and Dr. Leni. But I want to talk to the students something. The postgraduates, please remember, this what you will think is a very easy case. That is where the problem comes in. Exactly like Lalit said, you make one mistake in this, is going to be a problem. And very unlikely that case will not be without a catch. Again, like you said, look for something. The scapula osteochondroma may be beneath the scapula. Then you will find something like a pseudo winging. So that is number one. There could be a complication. So look for those things. Don't forget. And you will definitely get one tough question, because it's a very easy topic. There are case reports where osteochondroma has completely disappeared of its own, complete resorption. It is again given in the literature. So the examiner might ask you something more than what is expected in the MBBS level. But overall, it's a very common case, and be prepared for it. And I am sure that talk was very useful. Thank you, Dr. Brajesh.
Thank you. Actually, there is slight change in program because Dr. Raju, he is not well, and Dr. Maravi has to leave for COVID duties. So we have to fill that gap. Dr. Brajesh has few slides of X-rays, so we can have a discussion.
Sir, Manish sir.
Yeah.
Give me 5 minutes. I am preparing that presentation. Give me 5 minutes only.
Okay, then we can have discussion on other topics.
I am compiling the 4 or 5 X-rays, and then you can have the discussion over that.
Dr. Rajgopalan, we can have discussion on the previous lectures.
The first lecture was on enchondroma, osteosarcoma, and first one by Dr. Magu was on osteosarcoma. I mean, actually, all this we have discussed quite well. But the thing is like this, that if you get an osteochondroma, there's no problem in a differential diagnosis. Quite often, if there is some other case, I would have kept that for post-graduation. So you may get a benign swelling. You may not know what it is unless you have already seen the patient. That is where the problem. If you have not seen the patient, I'm addressing the students actually. If you have not seen the patient, then it is easier for you because you don't know what it is. Let me say he has seen the X-ray, he has seen the MRI, he knows it is ABC, he will present it as ABC. That's going to be a problem for you. You look at the age, you look at the bone involved, and look at whether it is eccentric, whether it is involving metaphysis, epiphysis, diaphysis. You go by clinical examination. Even if your diagnosis is wrong, your findings are all right, still you get a better one. So there will be cases like that. As Dr. Magu said, even though if, undergraduates, we teach metaphyseal, in Dalton series, osteosarcoma was 40% diaphyseal. So these things have limitations when you come to an individual case. So it is better that when you get a classical osteochondroma, different. Otherwise, like an enchondroma, we're talking about it, you will not know clinically sometime what it is. So only you say it's a benign or malignant. What is the difference between a benign lesion and malignant lesion? And a lot of other things which are already told by the other panelists, another faculty. So that is the most important thing. What is very, very harmful for you is, I have seen the case, I don't know what it is, I'm just thinking it may be a malignant lesion. You correctly come and say it's a chondrosarcoma with all the findings. Then we get a doubt. So what is important, don't see the X-ray. That's the number one thing I want to say. Lalit, you can take on that.
Yes, very rightly said. If you have seen the patient, it really blocks your mind, and you are not able to sort of face the question of what is your differential diagnosis or why do you say so? Because you start thinking that obviously it is osteochondroma. What do you mean that what is your diagnosis? And the subtle things like common complication is a neurovascular compression. So if it's a fibular osteochondroma and you have not been careful in checking up the nerve part distally, you might miss a subtle neurological examination, which when the examiner tries to examine, it comes up and then you are in a difficult soup. So in a short case, in a tumor, we are basically trying to assess your systematic way of evaluating a swelling and the broad categorization between a benign and a malignant bony swelling. So remember, most of your examiners are not going to be oncosurgeons. They're going to be general orthopedic surgeons, and they would like you to have an approach towards a swelling, and that needs to be done well. Dr. Harshad?
Dr. Harshad?
Yeah. I think I have a story like what Dr. Rajgopal has said. I had gone as examiner, and there was a case of at the knee joint, a giant cell tumor. So I think all the students had seen it. So if they are unlucky, they get a chance to see the patient and the X-ray. And then when the student came there, this patient particularly was shifted out because she had pain and another osteoarthritis patient was kept there. This patient presented everything about giant cell tumor. X-ray of osteoarthritis, he also identified giant cell tumor and showed a lesion. That much our mind goes towards that side. So you have to be extremely careful and neutral regarding all the things. It is best to get your clinical findings and then X-ray findings and then discuss non-committently if you have to pass. I think that's the best message that we can pass.
I just wanted a advice for our students that is there any necessity to have a separate book for bone tumors before they go for the case? Is it necessary, or you recommend some book for that?
One simple guidelines which I had made for myself. Okay, Manish. Hello.
Yeah,
we can hear you.
Yes, sir.
Yeah. Okay, is the most important tumors, benign tumors, 5 tumors, malignant tumors, 5 tumors. You make a list, make a master chart of that with the most important findings, and you behead that and try to keep writing on that. Then beyond that, you can always write more and learn more. But that much you should know. That guidelines will help you a lot for your own revision as well as this one. That is how it has helped me in my own career, undergraduate time as well as postgraduate time, because oncology is a huge, very huge this one, and there are too many conditions and things that we have to remember. So I think it should be easy. Dr. Das should be able to give us a short guidelines or send us so that next time you can just put it up saying that this is the master chart for malignant tumors, the most commonest being osteosarcoma, osteochondroma, and maybe in between malignant giant cell tumor and 1 or 2 others. And most important, these are the findings for these various things regarding age, regarding common site, regarding most important clinical finding, most important this one, as well as treatment. For example, you won't require treatment of radiotherapy for one condition, whereas Ewing melts. That is how it is. So you can make a basic guideline to see that the postgraduates know that chart. Once you know that chart, I think it will be difficult to fail. Rest of the things, it's just fill in the blanks.
Yes, sir.
You have to make things easy for you. Tumors being not so common in our practice, I think that's the simplest way.
Thus,
yeah.
Manish?
Yeah. So,
Dr. Das,
Dr. Das, please.
Continue, please.
Okay. Dr. Rajgopalan, you wanted to say
I
something?
want to say something, Manish. That is, your question was about the book. Plus, really speaking, when I studied my post-graduation, that was 1976, we had only one Campbell book with 2 volumes. We had either a Mercer or a Turek. And there's one book for trauma, that was Watson Jones. Today, the students have much more to read. I think. So I feel, let them read the bone tumors from any one of the standard textbooks. But For the, like what probably Shah said, for the exam topics alone, if they want to get the extra mark, they should read there are very good books are there. I won't even know, but during my days, I had a lot of time to read because we had a lot of tumors. Dr. Yadav was basically doing a lot of tumors. So I used to read Diggert and Kirkpatrick, Mira, and we had Dalin's book, Jaffe's book. So all the books we read. But today they have a lot of things to read. So I feel asking them to read another book on bone tumors, I think 3 years difficult. My opinion.
I think
Raghupalan sir?
retrospectively, you must know what tumors are coming to you as questions in theory, in clinics, and
Yeah.
then read about them through various
Yeah,
books,
very good
whatever you
suggestion.
want. With
Very good
Raghupalan sir?
suggestion. Yeah, yeah.
Can I share the PPT?
Yeah, please go on.
Yeah,
Manish,
sure.
please excuse me, Manish. I have to
Yeah,
go.
yeah.
I'm already late. I told them 7
No
to-
problem. No problem.
Sorry, Shah, I'm sorry. I had a plan to talk to you.
Don't
but we'll
worry,
do
don't
it
worry.
later. It's our state meeting, so I have to go. Thank you.
Thank you, Rajgopal.
Dr.
please-
Ravi, yeah,
Please go ahead
first
for the
case.
discussion.
Yeah, please discuss the X-ray, Dr. Ravi.
Sir, hello. Brijesh sir?
Yes, yes.
Brijesh sir?
Yeah.
Yeah,
please
Dr. Brijesh.
take on from here.
Yeah. Should I send more?
No, no.
No, you start discussing of this case because these are your X-rays.
Okay. This is a X-ray of hand, right hand, AP and oblique view, and this is showing a lytic expensile lesion of the shaft of the fourth metacarpal, and there is a ground glass matrix which is evident in the X-ray, and cortex are intact. There is no, although there is a thinning of cortex, but cortex is intact. There is no endosteal scalloping as far as X-ray is concerned, and the probable diagnosis is enchondromatosis.
Dr. Brijesh, can there be a differential diagnosis also?
Yeah, then it can be enchondromatosis. It can be tubercular dactylitis.
Okay. Dr. Harshad.
Yeah. I have one more observational finding. There is one more lytic lesion
At the
proximal
base
to
of,
that.
at the base.
So there is there is a skip lesion.
There is a
What do you
skip
think of
lesion
that?
and adjacent lesion. So the osteomyelitis can be the one differential in this case.
So don't you think of infection first and then something else?
Yeah.
When it is expansile, can it be some vascular lesion?
Usually vascular lesions are very uncommon in
Uncommon, I know,
metacarpals
but
due
can
to
you think of
vascular
it?
pattern, due to that particular vascular pattern in metacarpals or phalanx.
No, but if you consider the midshaft lesion only, I'm not talking about the skip lesion.
Yeah.
We will discuss that later. The midshaft lesion, when there is an expansile lesions, aneurysm, even giant cell tumor.
Yeah.
Can be this.
Yeah, even giant cell
If you
tumor
ask
or
me to
ABC
describe,
can be there.
you have described it in a beautiful way in your way. I will say there is an expansile lytic lesion with septae.
Yeah, with septies.
And thinning of cortex.
Yeah,
So with these points, diagnosis, we put it as giant cell tumor, of course. Then the site is a rare site, but it can be there. The X-ray findings are like that, but you do not get skip lesions in those conditions, isn't it?
Yeah, okay. Professor Manny.
One second, sir. One more small point. The epiphysis, Brajesh?
Yeah.
If the epiphysis is present, it cannot be giant cell tumor, isn't it?
Yeah, it cannot be giant cell tumor. In a
very
skeletally immature patient, this is a very rare thing.
I think, yeah. So Brijesh, this is the treatment. Can you explain the treatment?
Yeah, so I did the biopsy and it was in chondroma.
The sound is not, I don't know, something.
Hello?
The whole thing had stopped. Your internet connection is unstable. I think that's what is coming on the board.
So now, am I audible?
You get it, Brajesh? Yeah.
Yeah. So I did the biopsy, and I get an elastic soft fibrous tissue. The biopsy report was enchondromatosis. So I excised the wall of the tumor, put the fibula, a unicortical part of fibula, not a whole fibula, fix it with a wire, and put the hand in the plaster for 6 weeks. After 6 weeks, I removed the plaster and start the physiotherapy and hand movement, and the final X-rays after 12 weeks, which shows the incorporation of graft, and the total follow-up is 2.5 years. There's no recurrence, and functionally there's no disability or no any kind of deficit in the hand. She is a female child of 14 years.
Okay. Dr. Das, your comments? Dr. Das?
Yes, the first diagnosis should be the enchondroma, and subsequently the other lytic lesions should come in the differential diagnosis. But the treatment which was provided, this is fine, and the result is also fine.
Dr. Brijesh, can I ask you one thing, that in exam, sometimes it
Yes,
is
sir.
asked that what is spina ventosa? Can you put a light, because this question is sometimes asked in the exam.
Yeah, spina ventosa is a intraosseous, I mean a tubercular osteomyelitis of digits, I mean metacarpals and phalanx, where there is expansile swelling, and radiologically sometimes it is difficult to differentiate it with the any other non-infectious lesion like enchondromatosis or non-tubercular osteomyelitis.
Okay. Professor Mani is there? I think he has logged off. So we go to the second case.
Yeah.
Dr. Ravi, put the second case. Yes, Dr. Brijesh. Can you
So,
just give the history?
This patient was a 29-year-old male presented with the multiple swelling and deformities of the joints, inability to move the joint. There is a mechanical block of the thumb movement. There is a pain. There is a callosities and pressure source over the toes, and on X-ray evaluation, we have seen a multiple such swelling in hand and foot, and he was diagnosed as a case of multiple hereditary exostosis. So this is the X-ray. It shows multiple exophytic growth at the tip of the phalanx, distal phalanx, along with a cauliflower and exophytic mass with comma cleft or flocculent calcification, along with ground glass hazy appearance, seems to be a cartilaginous cap. Sir, you are muted. Manish, sir.
Dr. Brijesh, yeah, Dr. Brijesh, what is your differential diagnosis?
Sir, in this case, my only diagnosis is a multiple hereditary exostosis. There's no differential of such kind of swelling or such kind of cases.
Is there any specific syndrome is there where there are multiple hereditary exostosis?
Yeah, there's a Ollier syndrome, Maffucci and Ollier syndrome, Ollier's disease, where we can find a bit, but again, it's a part of this MHE is a part of that's multiple exostosis is a part of syndrome, but there's no other differential other than multiple exostosis.
Dr. Das, your comments, please.
It seems Ollier's disease.
Yeah.
Radiologically and clinically.
Okay. Dr. Harshad?
I do not know the diagnosis. It's very rare. I have not seen something like this. It is for people like Brijesh to diagnose. Das has already told and confirmed about it. So, except maybe they were discussing about Maffucci syndrome associated with these conditions. I do not know whether it occurs on the foot. Can you take your slide back? Dr. Brijesh?
Yeah, sure, sir. I'm taking.
Ravi is
I'm taking
presenting,
it.
no?
I'm taking it.
Yeah, if you see all the soft tissue swellings that are there on this one, I don't know whether these kind of swellings you get in any kind of fungal infections and other things. I'm not sure.
Usually
But
such
I personally feel, Brijesh, the one of the differential diagnosis can be gouty tophi clinically. If you're not seeing the X-ray, gout can present like that.
Correct. Gouty tophi also look like that. It's quite difficult to.
This is not gout.
Can I move it further?
Yeah. Go to case number 3. Okay, Dr. Brijesh, please. This is your case. I know it.
Yeah, 15-year-old girl previously operated for same condition. Yeah, this was a 15-year-old girl presented to us with the swelling gradually increasing at the proximal leg and inability to move her leg. Swelling was painful, and the total duration of swelling is of 6 months. A year earlier, she was operated for the similar swelling. The swelling was removed, and in last 1 year, it again reappeared at the same site. So this is, yeah.
Yeah, no, Dr. Brijesh, continue, please.
Yeah, this is the plain X-ray of left knee showing the distal part of femur and proximal part of tibia and fibula along with the knee joint. And the X-ray is showing there is a lytic destructive lesion at the metaphysis of the proximal tibia along with the soft tissue components, and there is a soft tissue shadow. Fibula seems to be intact. There is a evidence of radiological evidence of cortical destruction laterally, and the only thing which is one more thing which is important to mention is there is a narrow zone of destruction between a tumor tissue and the normal tissue.
Okay, what is your diagnosis, Dr. Brijesh?
My diagnosis is first diagnosis is osteosarcoma. Second diagnosis is aggressive giant cell tumor. A giant cell tumor. Third diagnosis is any malignant mesenchymal tumor can be there.
So first diagnosis, what you will keep?
So in any case, in such case with such presentation, I would like to further investigate the patient in the form of MRI to see the local picture, and after MRI I would like to go for the biopsy. If biopsy will show the malignant pathology, then I would like to go for a metastatic workup by CT chest or PET scan of the whole body.
Why not before biopsy?
Pardon, sir?
Why not get a workup done before biopsy?
So usually some kind of benign aggressive lesion present like this. So before biopsy, if we are 100% confirmed that this is a malignant pathology, then to save time, we used to go for metastatic workup at the time of before biopsy. But as per the HSCC guideline, we should first diagnose the lesion, then we should go for the metastatic workup.
So you're not wrong if you do biopsy first and then do all the other workup.
Yes, sir.
Including PET scan?
No, MRI should be before the biopsy.
Because MRI and PET scan will decide what to do for in a large number of patients, isn't it?
Yeah, MRI guide us the proper site of biopsy, the more representative site for biopsy, and after biopsy, MRI can give a false picture due to inflammation of biopsy.
Okay, Dr. Das, your comments. Dr. Das.
What Brijesh has said, the diagnosis should be like that order. Fine. Other procedures should be followed as per his comment.
Okay. We move to next case, case number 4.
Can
Sorry?
we go back, Manish?
Yeah, we can go back.
I had one question for Brajesh.
Sir,
X-ray findings are not typical of giant cell tumor. Why did you think of giant cell tumor?
sir, first age. The first point is age of patient. Second, even if giant cell tumor, the cartilage is a barrier for expansion of giant cell tumor. And if you say the lateral view and epi view, the joint line is preserved.
Reserved.
And for giant cell tumor, this kind of picture is not common, but this is a recurrent case. So you can find such finding in recurrent giant cell tumor.
Yeah, otherwise, the postgraduates will be carried away. That hazy kind of a thing, without any septae, without anything, without any lytic kind of a lesion. How can we think of giant cell tumor? That's the reason I asked this question.
Yeah, even sir, if I have a biopsy report of other centers showing the giant cell tumor, I would like to consider it as an osteosarcoma until unless a specialized histopathology will tell me that is a giant cell tumor.
Yeah, because the same question you asked for the dactyl, the other case that you presented,
yes,
I would have told them why it is not giant cell tumor. Number one, you said that it is a rare area. Number two, it is an adult bone, it should be. Otherwise, this one. Number three, it is not epiphyseal-metaphyseal junction, the one in the dactylar presentation of yours. You understand?
Yes,
so
yes.
Those are, and then eccentric starting, of course, afterwards it covers up the whole thing.
Yes.
Okay.
Okay, we come to case number 4. Dr. Brijesh.
Yeah. So it was a case of 6 years old girl child, and she presented with the pain, huge swelling in her right arm from from elbow up to the shoulder, and she was presented with a wrist drop, involvement of radial nerve. So we advised the X-ray. X-ray is showing. So now come to the X-ray. This is the X-ray of right arm, including shoulder and elbow joint of a skeletally immature patient. Now X-ray is showing there is a permeation or permeative lesion along with the hair on end kind of periosteal reaction with some lamellar kind of periosteal reaction also along the diaphysis of the femur from from the metaphysio-diaphyseal proximal metaphysio-diaphyseal junction to the distal metaphysio-diaphyseal junction of the humerus.
What is your differential diagnosis?
Can you go back to the previous X-ray? So this kind of picture, there are 2-3 differential diagnoses in such a young child. First is a Ewing sarcoma. Second is a lymphoma. Third is any kind of blood dyscrasias.
Okay.
Osteosarcoma. Chronic osteomyelitis.
Chronic osteomyelitis.
Yeah, chronic osteomyelitis can be there. Just a minute.
But Brijesh, we also can see something like this periosteal reaction. It sometimes looks. Why can't it be osteogenic sarcoma?
Yeah, excuse me.
See, if you can see periosteal reaction as something like sunburst, why can't be a differential diagnosis like osteosarcoma?
Look, osteosarcoma can be a differential diagnosis, but if you see the X-ray closely, there are 3 variants of osteosarcoma. First is an intramedullary variant. Second is a periosteal or parosteal variant. Third is a soft tissue variant. So radiologically, it can't fit into any variant of the osteosarcoma, because intramedullary variant, we have a osteoid tissue, intramedullary osteoid tissue, we have a cortical destruction, and one characteristic feature of Ewing sarcoma is a periosteal reaction in the diaphysis along with a large soft tissue homogeneous mass. So as a student is concerned, they can put osteosarcoma in differential diagnosis, but they need to exclude it by these points.
Okay, Dr. Brijesh, what investigations you will do for him?
Same, any case of tumor where we consider it a malignant tumor, first we should radiologically investigate as well as serologically investigate. So I would like to go for MRI in this case, and MRI was showing the huge soft tissue mass along with the permeation and the intramedullary involvement of the proximal and distal part of the throughout the humerus. So we did the biopsy, and biopsy shows Ewing sarcoma. In Ewing sarcoma, nowadays, as per the protocol, we go for neoadjuvant chemotherapy. I mean, chemotherapy before surgery, and then the surgery, and again the adjuvant chemotherapy. So this is the X-ray of the humerus after 9 cycle of chemotherapy.
Okay.
So after 9 cycle of chemotherapy, we went for surgery. After chemotherapy, we again went for MRI. MRI shows the active tumor tissue are restricted to the mid diaphysis. So we excised the diaphysis from the active tumor 2.5 centimeter margin proximally and distally. So this was the whole diaphysis which we excised. In the center of diaphysis, you can see the active tumor tissue in the form of necrosis, and we have replaced the gap with the fibula and reconstruction plate. And so the next slide. So this was the picture after 9 months. So complete incorporation of fibula and movement. There's no restriction of movement, and strange thing was her radial nerve palsy was completely recovered.
You didn't mention
Okay.
about radiotherapy.
No, sir. Nowadays, we used to go for radiotherapy only in Ewing sarcoma when margins are close. Otherwise,
When?
nowadays the main therapy is a chemotherapy, preoperative and postoperative. Radiotherapy is not in a regular protocol in Ewing sarcoma. It is a discretion of surgeon whether he wants to refer for radiotherapy or not. It depends on excision margins, and there are one main criteria for which you can send for radiotherapy, like if you give when you give a neoadjuvant chemotherapy and then you went for surgery, if you excise the specimen, send for histopathology, if it is showing more than 95% necrosis of the tumor cells, there's no need to go for radiotherapy. If the chemo response is type 2, I mean less than 90% tumor cells are necrosed, then you should go for induction chemo, adjuvant chemo and radio both. And in that case, you have to change the chemo regime as per preoperative chemo.
But Dr. Brijesh, I think radiotherapy has to be mentioned by postgraduate, because
Yeah,
these
radiotherapy, how does it help?
For postgraduate level, I think they have to mention radiotherapy, because
Look, sir, there are two
How
things.
does-
There are two things. Now things have changed and more clear. First, look, chemotherapy is two broad thing. Chemotherapy is to give a systemic control of the tumor as well as local control of the tumor. Radiotherapy has no role in systemic control. It only gives a local control. So if local margin is clear, there's no role of radiotherapy in all kind of sarcoma.
All right, that's the general principle. But what
Yes.
has been taught is that Ewing's was very useful. I think this was the tumor where radiotherapy melts, isn't it?
yes.
The
Yeah,
Ewing's sarcoma.
it was the teaching, sir, but
Now you
nowadays,
have to stop that melting
yes,
messages
sir.
to the postgraduate.
Yes,
Huh?
yes, sir.
Okay.
Dr. Das, your comment.
What does
Dr.
Dr.
Das?
Das say about it?
Nothing to do.
Pardon? Das? No,
Dr. Das, we can't hear you.
I think his video has stopped.
Yeah, video
I
is
think.
stopped. I think
No
some
problem. We
connection problem.
go to case number 5.
Yeah.
Dr. Brijesh.
So it's a very good case. This was a 29-year-old male presented with a gradually increasing swelling of the right wrist since last 9 to 10 months. The swelling was gradually increasing. There was a restriction of movement since last 2 to 3 months. We have advised the X-ray. X-ray is showing thinning of X-ray is showing there is a lytic lesion at the metaphysis of the right radius, along with the expansion, along with honeycomb appearance of the matrix. So my first differential diagnosis is aneurysmal bone cyst, and second differential is a giant cell tumor.
Okay. Dr. Harshad.
I don't know. Aneurysmal bone cyst, I think it's too big. Generally, it begins in children, and slowly, as the limb grows, it also comes down, just like a unicameral bone cyst. So this seems to be more likely in an adult with skeletally measured bones, as probably giant cell tumor only to me.
Dr. Das.
And then
Giant
Dr.
cell
Das.
tumor. Giant cell tumor should be the first diagnosis, and then aneurysmal bone cyst.
Okay. Dr. Brijesh, how did you manage this case?
Sir, there is one thing which, there is a very good book, Principle of Orthopedic Oncology, which shows the collection of 300 or 400 cases of aneurysmal bone cyst and giant cell to compare the radiological feature. So if you see, there is a very good differential sign of GCT and ABC. If you see, there is a junctional sclerosis at the normal bone and a tumor lytic bone, then it is more likely to be ABC. If there is no junctional sclerosis, then it is a giant cell tumor. And this becomes true in more than 90% of cases if you analyze the X-ray. So if you see on ulnar side, there is a periosteal reaction. There is a buttress type of periosteal reaction in this case. That's why I considered it as an aneurysmal bone cyst. So I further advised MRI, and MRI showed a clear fluid level in this case. So I aspirated, and it was a clear bloody aspirate. And then I put a polydocanol, 3% of polydocanol. There are 3 sittings in the gap of 4 weeks. And after 6 months, the lesion was completely obliterated.
Dr. Brijesh, if suppose it's a giant cell tumor, you can use the polydocanol?
No, sir. Basically, polydocanol is a sclerosing agent used by vascular surgeon for varicose veins. So if you go into pathology and biochemistry of this aneurysmal bone cyst, this is considered as a arteriovenous malformation, intraosseous arteriovenous malformation. So a sclerotic agent is used in this particular pathology only, and it works in this particular pathology only. In giant cell tumor, we used to give a denosumab to decrease the size of tumor, to delineate the normal and abnormal tissue, and then we have to operate. There is no sure shot treatment in giant cell tumor by denosumab. But in ABC, you can put a polydocanol, and you need not to do anything further if it responds.
Is biopsy required before this giving injection?
If MRI clearly shows fluid level, and there's no destruction of cortex, then you can take a biopsy at the time of injection. What I used to do, I put a core needle and do a curopsy kind of thing, remove some part of membrane and send for the biopsy at the time of first injection to confirm my diagnosis and to document the diagnosis. Because sometimes telangiectatic osteosarcoma can present like this also, but presentations are very different in that case.
Okay. Any comments from Dr. Harshad?
Thank you. He has told everything very well.
Dr.
Dr.
Das?
Das can add something to it.
Okay, we go to case number 6. This is the last case of the evening.
Sir,
Yes, Dr. Brijesh.
Actually, Ravi put this second X-ray. It was a case of 23-year-old girl with the same diagnosis, invisible bone cyst, and this was the X-ray after first injection of polydocanol. It is showing the obliteration of it started showing the obliteration of lesion, and after 2 more injections, this whole lytic cavity was obliterated. So this was the first. This was the X-ray after the first injection.
Okay. So any comments? I think it was a very nice X-ray discussion also.
Yeah.
So any comments from the learned faculty? Dr. Harshad, you are the senior most now. I think Dr. Das is eager to you.
Now, saying that this was a very good program, probably very useful for all postgraduates. Basically, to see that they get more confidence in presentation of their cases and see that how they do not fail. So these presentations of Dr. Das and Dr. Magu and Rajesh, as well as all the cases and all that, were very nice. I think that covers up most of the things required for this one, but they do have a lot of theory to read behind for any questions that are asked by examiners that the postgraduates can read by themselves. I think clinical examination and then discussion about this is important. Brajesh has something to say?
Sir, as far as I understand, and I have seen in exams, for postgraduates in practical exam, if they are given a case of tumor, a proper history, examination, and proper elaboration of the X-ray finding is enough to pass them.
It's enough, yes. So it's not very easy to fail. I think Das wants to say something.
No, nothing to add. Nothing to add.
Your expert comments, I think you should be the one who should give along with Brajesh.
No, actually, if any postgraduate student proceed maintaining the basic norms, then there is no chance of getting fail in the examination. First of all, they should take the history properly. They should, from each and every step, they should collect the information, and accordingly they should come to a conclusion what is the provisional diagnosis. And once the provisional diagnosis on the basis of clinical examination and history they achieve, they should ask for certain basic investigations. And if they proceed by step like this way, then definitely they should get through the examination without any difficulties.
So I think it was a brilliant program, and I think we should wrap it up, because the only unfortunate part was that 2 speakers fell ill and they had to leave, and they could not join. So I think we meet next week. Dr. Harshad is in charge of the external fixation program. So we'll come up with a very nice program for the next week. I think it is in 2 parts.
You also, right?
Yeah.
I have discussed already with you. Ravi, you're still online with the program?
Yes, I am there, sir.
I know you're there. No, the program is still online being recorded.
Sir, let me make it offline.
Offline.
Make it offline, then we can.
No, 1 minute. I have to thank Dr. Shamsul Huda.
Yeah.
I have to thank Dr. Ravi Chauhan for their cooperation, because they are the people who.
I have come, Manish.
Dr. M.M. Ray.
The invisible man.
we were looking for you, and we wanted your expert comments. We were looking for you, Dr. Ray.
I have just come because anyway, that you have organized this thing very well. And I have no doubt that Dr. Das this time is here, and we are doing it. And Dr. Harshad, under his leadership, it will be definitely very good program. I hope everybody has enjoyed it.
Yeah. And Dr. Ray, we had a very beautiful discussion on 6 X-rays, because though 2 speakers were not there, so X-rays were put, and it was a very nice discussion on X-rays.
I'm sorry, I missed it. I had
the live stream now.
Yeah, you can stop.